It's a great pleasure to come back to Coimbatore into this wonderful hospitality. The last many hours have been an immense learning experience for me personally. Listening to Professor Jones has been a learning experience in more ways than one. The content, well, is not an issue at all. We can vouch for it. But what I am amazed at is his ability and stamina to give so many back-to-back lectures. I can tell you from personal experience, it is a Herculean. I must compliment you for this. And I must thank Matthew for actually giving me this opportunity to listen to Dr. Philip Jones for so long. Now coming back to the topic of my lecture today. How does this work? Okay. So what I am going to try and do over the next half an hour or so is to give you some insight into this rare group of angiographic abnormalities, the so-called pulmonary arteriovenous malformations. Now normally what happens is that the pulmonary artery comes out of the right ventricle in midline, and then it divides into two pulmonary arteries, that is the right and the left pulmonary arteries, and then these end up in a network of capillaries, and they communicate and drain into the pulmonary veins. Sometimes because of abnormal development, these arteries and veins communicate directly in the absence of capillary channels. This is when pulmonary arteriovenous malformation develops. So essentially, pulmonary arteriovenous malformation refers to the absence of the capillary network between the pulmonary artery and the draining pulmonary vein. Now this group of abnormalities is distinctly rare, as you can see from the prevalence, but when they happen, they are 2 times more common in the female sex, and they are usually seen in the pediatric age group. Majority of the patients are seen in the first 3 decades of life. Usually what happens is that there is a single draining artery into this malformation, and there is a single draining vein which drains into the pulmonary vein. So a single draining artery and a single draining vein forms a simple pulmonary arteriovenous malformation, which is seen in majority of the patients. Occasionally there may be more than one feeding artery and or more than one feeding vein, when it is referred to as a complex pulmonary arteriovenous malformation. Now majority of these solitary malformations, which are far more common, they are not more common, but they are common. They usually happen in the lower lobes and more often on the left side than on the right side. So essentially what you would see in an asymptomatic patient in a chest radiograph taken for whatever reason, a solitary nodule or a solitary lesion in the left lower lobe, which is the most common way a pulmonary arteriovenous malformation would look like. About 1/3 to half of these patients have multiple pulmonary arteriovenous malformations, and when this happens, it is usually a part of a complex or a syndrome complex. Most of these malformations are congenital in origin, and when multiple, they are associated with this Osler-Weber-Rendu syndrome, or also popularly known as HHT, which stands for hereditary hemorrhagic telangiectasia, which is a syndrome complex which involves the liver, which involves the GI tract, the nasal mucosa, and also in the brain. Now it is important to identify this syndrome complex. Why? Because when pulmonary arteriovenous malformation happens in the setting of hereditary hemorrhagic telangiectasias, they have much worse symptoms. They oftentimes have multiple malformations, and the disease progresses much more rapidly than when pulmonary arteriovenous malformation is seen in isolation. Also, these patients have much higher complication rates of the natural disease or natural progression of disease vis-a-vis isolated simple pulmonary arteriovenous malformations. Now, majority of these malformations, as I mentioned to you, are congenital in origin. However, occasionally these can be secondary to a variety of disease processes. As you can see in this case, this patient has pulmonary tuberculosis, actually had a small pulmonary arteriovenous malformation which we embolized some years before this chest X-ray was taken, and he came back with the development of a larger pulmonary arteriovenous malformation over a period of time. So the moral of the story is that in our setting, pulmonary tuberculosis is a cause of secondary cause of development of pulmonary arteriovenous malformations. In specific geographic locations, schistosomiasis is also known to produce pulmonary arteriovenous malformations. In addition to these metastatic malignancies, mitral stenosis, liver cirrhosis, etc. can also produce pulmonary arteriovenous malformations in a small select patients. Whereas majority of these patients will have an abnormal pulmonary artery leading to the malformation and an abnormal pulmonary vein draining the malformation. In a small group of patients, there can be systemic arterial supply to the malformation and or systemic venous drainage from this malformation into the systemic veins. It is important for you, if you are going to set out to start embolizing these malformations, to know that sometimes these can drain into the inferior vena cava or into the net vein as well. So therefore, optimal understanding of the anatomy is critical for deciding the treatment strategy in this group of patients. Mostly, these patients are asymptomatic and are detected on a routine chest radiography for medical purpose or for whatever other purpose. Typically, single malformations which are smaller than 2 centimeters in diameter do not cause symptoms. Symptoms happen far more commonly if malformations are bigger or if these malformations are multiple. The classical symptom complex is a patient who develops dyspnea on exertion, who gets blue on exertion, and who has clubbing. This classical triad is typically identified with pulmonary arteriovenous malformation, but is seen in only a small group of patients. Hemoptysis, in addition to dyspnea on exertion, remains the most common way these patients present to us for management. Now, because of their inherent anatomy, they produce a right to left shunt, and this shunt causes a lot of problems. It produces high output cardiac failure. It can produce paradoxical embolization and cerebral abscess. So these neurological complications are the most common way a symptomatic pulmonary arteriovenous malformation presents. As many as 40 to 50% of these patients will develop some form of neurological complication. So with this background, let us try and see how can we approach a given patient of pulmonary arteriovenous malformation. What should be the goal of imaging in a given patient of pulmonary arteriovenous malformation? The first question which you have to answer is, does this patient have a pulmonary arteriovenous malformation? So the imaging or some form of investigation can define this. If the malformation is present, what is the percent of right to left shunt, that is the ejection, the shunt fraction, what is the shunt fraction? Because this will prognosticate the outcome of treatment as well as the indication for treatment in a given patient with pulmonary arteriovenous malformation. So once you have defined these two basic questions, the next question you have to answer is, should this patient be treated for the arteriovenous malformation? There are many factors which will decide whether, once we have established the diagnosis of pulmonary arteriovenous malformation, should we progress to treat this patient? These include the size of the malformation. Malformations beyond a certain size have a higher incidence of morbidity and mortality, and therefore they should be treated standalone, whether symptomatic or asymptomatic. Malformations which produce progressive hypoxia should be treated irrespective of the size. Is there associated pulmonary arterial hypertension in the setting of pulmonary arteriovenous malformation? This is an important factor because this prognosticates the outcome of treatment, whether embolization or surgery. We will address this shortly. Malformations which have complications, whether neurological or whether cardiac in terms of high output failure, should be treated. And lastly, malformations of a given or suitable image morphology can be treated either by surgery or by endovascular means.